Thank you, and I can testify as to how long HRSA's been involved in this, because back in the late 70s, NIH had funded the first phase of some of my work, and they wouldn't fund the second phase because it cut across too many of their areas. They said, it's obstetrics, but it's also pediatrics, but it's also, and too much community. And this was research on improving pregnancy outcomes in diverse populations in Los Angeles, and HRSA funded my work. So HRSA got it a long time ago, and thank you, all these years later. We now have an opportunity for other sponsors. So I think for those of you who may not be familiar with the model, when a project like this is proposed, it needs sponsorship, and people come together and say, I will buy into this, I believe in it. And you've heard from 3, and there are other forum members who are also sponsors of this work, and so I'd like to give any of you who would like to say something an opportunity. I think we have an open mic, yeah. Lucinda.
Thanks very much. I'm Lucinda Main from the Forum and representing the Association of Colleges of Pharmacy. And as I think about the enormity of the task before you, I just have a couple of thoughts. One, you know that the pendulum has swung too far. So it used to be that there wasn't much in the toolbox of healthcare, and the community had to be primary. And in the last 50, 60 years, the pendulum has swung, I think, too far in the other direction. My fear about bringing social determinants more prominently into our health professions curriculum is that they're going to throw up their hands and say, I can't do it. And so it's critically important that we enhance our education in this domain. But I'm familiar with work similar to that, which Gary Gunderson has done initially in Memphis, now at Wake Forest, where he's purposefully trying to knit community and healthcare delivery back together again. And he did it, I think, quite successfully in Memphis. And I hope that some of those messages or those lessons appear in your report so that we can share them with our learners, for them to look for those community structures wherever they may be practicing, because healthcare delivery can't do it by themselves and the community can't do it by themselves. It really does require bringing us back together again.
Yeah, good point. Other sponsors who would like to speak up? Or other members of the forum who'd like to say something? Okay, then I think we have an opportunity, actually, for those of you who have gotten this remarkable charge to ask questions of our panelists, and actually of other forum members certainly can speak up if they'd like. This is your chance to sort of refine what's expected a little bit.
Thank you for Tony Villarreal, University of Pennsylvania. Thank you for sharing your perspectives. As we think about these frameworks, I would ask your perspectives on what do you think is missing from existing frameworks, because there's a variety of them. So as we're looking at putting one together, adopting one, what do you see as missing?
Did everyone hear that? I wasn't sure it carried. Okay, so how we reconcile this with existing frameworks and whether you're looking for a brand new one. Go ahead.
I thank you for the important question. Many of the frameworks that we've reviewed stop at the triple aim, which is a wonderful place to be. If you can say that you improve population health, you improve the experience of care, and you lower costs while you're doing it, that's fantastic. But we also want if we're talking about social determinants, to go beyond that. And again, I've said this before, to look at health equity as the ultimate goal, the reduction of health disparities, because you can achieve those really good outcomes in the populations that have the most resources first. But if you stop there, then you might miss the gap.
I was just going to reinforce the point about the equity and really having frameworks that drill down and help us understand, what works and for whom and when, in which populations does it work for. and to have that data that looks at that and from the standpoint of not only the outcomes, but also factors of engagement along the continuum of care, from engagement to an assessment point, diagnosis point, and then the initiation of treatment, and then a follow-up, and being able to track it across the continuum to see the engagement points, and then to have that drill down, that stratification that looks at it by the different populations to make sure that we're achieving equity.
Yes.
This is a question regarding HRSA. We really haven't seen an enormous flow of resources into social determinants of health or into public health in general. And I'm wondering if you could comment a little bit on your budget, of course, has been reduced quite a bit over the last number of years. Is this area now a priority for HRSA? And in terms of your budgetary resources, what kind of proportion of that do you see going into this area in the next year or two?
So I can't speak to budgetary priorities, but I know for an agency, our acting administrator, Jim McCrae, has voiced on several occasions that the social determinants of health is a priority for the agency, and because specifically with regard to the populations that we target. We've always targeted those rural, underserved, and other disadvantaged populations. And we're also very aware with our explicit mission to achieve health equity that you can't get there without addressing the social determinants of health. So we see that those priorities trickling down to the different bureaus and offices, and we are all been asked to engage in how to address this in a substantive way. The example that I did use was with our Division of Nursing, where we were able to use workforce diversity funding to shift that portfolio to explicitly focus on social determinants. But there is movement within the agency to look creatively at how existing funding streams could be used to amplify the work on social determinants.
Spiro Manson, University of Colorado. In closed session this morning, the committee had an enormously rich discussion about the potential for this set of analyses and the recommendations that might come of it. The greatest danger, of course, is enthusiasm married with breadth of scope in the context of the relatively limited set of time and resources available. I would like your sense, assuming that there is a deliberate, well thought through, and focused set of recommendations that comes out of this, what do you see very concretely the earliest, most specific kind of impact that this particular product would have? And I don't mean changing curricula across our health professional fields and increasing the funding of HRSA. I would really like to know what concrete impact you would like to have within the first 6 to 12 months after the release of this report.
That's an incredible question. But I was doing a journal club with my students, and it was on racial differences in premature birth. That was the topic. And we got into how are they going to influence it in their lives? How are they going to get at that? How can they make a difference? And they knew already, as these are third-year students, that they didn't have the time to do the kind of community engagement they wanted. They were already in the model of one by one, patient, problem, the next patient, the next problem, but they weren't happy about it. So if out of the report comes a wealth of ways that we can assure that they concurrently are engaged with communities, whether it's by another model or by different ways, or just stimulating that kind of education. That'd be a big step.
Hi. In thinking about the social determinants of health and health education, and you've just spoken to the difficulty of health professionals addressing this, our nation and even our public health system and our healthcare systems are absolutely smitten with the individual responsibility model for health. And whenever I bring up various health disparities, students immediately say we need to educate those people to have better health. Even if it's educating people how not to be raped, for example, which is pretty much unthinkable. So one of the things that we're going to have to think about with social determinants of health is how can we change various social or political or environmental or cultural policy issues that are creating ill health. And that is hard for health professional students, with the exception of, let's say, certain students, maybe public health, social work, that are encouraged to think on that level. Thank you.
Yes, good morning again, everyone. We've not yet addressed through social determinants or through active policy probably the most glaring issue when it comes to equity or inequity, and that's the existing question of racism as a structural component, an individually mediated component, and an internalized component vis-a-vis the work of Kamar Jones. So my question to the agencies that are represented here and others who will speak is, what is it specifically that your agency wants to do in relationship to identifying racism as a major SODH, and what specific mechanisms we put in place to once and for all rid that, so we can in fact have health equity and social justice in this country?
Another difficult question. Dive in.
So we approach that as a federal agency between, we don't use the language racism, but we do see the effects, and we do see the differential distribution of resources and assets. We approach that within the Bureau of Health workforce as that we do see people of color underrepresented in the lower ranks of the health careers. We spend a lot of time and energy and asking a lot of our stakeholders and partners about how can we collectively address this issue. It's not a training issue, and it has, again, historical roots that run deep. Trying to figure out how to redress historical roots of trees that are blossoming continually and flourishing is a complex question, and then we need partners, community and private as well, to help us. We do understand that that is the case, though. Again, the students of color get admitted to many of the institutions, but they don't graduate. They don't progress and they don't graduate. That's a systemic and sustained problem. It's not just in our majority schools, it's happening in our schools that have traditionally targeted racial and ethnic minorities as well. So there's a class component that's operating also that's been, mixed in with this. So I would love to hear feedback, get some answers from you all, and then we can go back and try to figure out how to create a policy or a funding stream to address it. But thank you for the important question. You're making me sweat, but we appreciate it, and we take it seriously, though.
That's okay. The minutes will reflect that HRSA is committed to eliminating racism and injustice in the United States.
I didn't say it.
Yeah. I'll weigh in on that one. We've been working on a project that we modestly call Achieving Racial Equity, and there's many sort of tentacles to that, but one of the things that we understand that is we have to be intentional about undoing racism. And we've been training social workers across the country and sort of a stronghold in New York City where it's really taken off, but really to train social workers in the areas of undoing racism at a sort of a micro level, meso level, and a macro level, with more focus at the macro level, and really integrating into that the responsibility of looking at things from a policy and a social policy perspective, knowing that we can deal with some of the individual racisms and so forth, but really at a structural society level addressing those things. And the undoing racism training, at the core of it, is really teaching folks how to do a power analysis. You know, how do you go into a community and look at the institutions within that community, from education to transportation to housing to child welfare, health, really the structures within that community, and you begin to do this analysis of looking at the outcomes, and you begin to say, you know, we ask ourselves the question, you know, why are people poor? And if you come up with an answer to that question that reflects back on that individual or that family, that's not the place we're trying to get to. Why are people poor? Well, the institutions that we put into place that would give people a chance to rise up out of poverty, to be economically self-sufficient, aren't working. So we need to go back in and look at those institutions. And just doing analysis at an institutional level, to, you know, for just an example, in child welfare, as a child welfare commissioner in the state of Massachusetts, our children of color were less likely, this is just one example, were less likely to be placed with a relative when they came into foster care. The white children, 30%, the African American and Hispanic kids, about 18 to 17%. So we started asking ourselves, well, you know, we got an African American commissioner, we got a Hispanic deputy commissioner, why is this happening under our watch? And we begin to say, well, it's the institution, it's the institutional policies. We've got to undo that from a power analysis perspective. And as we start to undo that, we went from, you know, 17, 18% up to 20, 26, 27, 28%. But as part of that undoing racism, teaching a power analysis at a structural level, and that's why I was saying earlier about we want our framework to be able to have a stratification where we're looking at data in terms of by different groups, who's getting the good outcomes, who's not getting the good outcomes, and what can we do to impact that.
Thank you. And we have two more comments from committee members, but before that, I wanted to say that a lot of us have been troublemakers at the IOM for many years, now the NAM, National Academy of Medicine. And the first study that the IOM published that really started to address this was probably almost 20 years ago now. It was commissioned by the Black Caucus of Congress. And the question was, do people have different experiences or risks related to cancer? Depending on race, ethnicity, and so on. And the title, and I was lucky enough to be on that committee, the title of the report was The Unequal Burden of Cancer. And it answered the question, but it also, I think, went a long way towards starting the conversation. There have been multiple reports out of the Institute of Medicine that have addressed this issue in many ways, and they inch, unfortunately, not quickly, move the dialogue, move our understanding of racism in this country, our understanding of racism and its effect on health along. This committee has an opportunity to continue that tradition as long as you're grounded in the evidence. Patricia would want me to say that. And there is plenty of evidence. I don't need to remind any of you of that. But you have an opportunity in this report, referring back to past reports, referring to the data, to do your best through educating health professionals to understand social determinants, to continue to erode the racism in this country that so deeply affects health. But we have two committee members who want to speak.
Thank you.
Oh, that's okay. You have yours on. Go ahead.
Okay?
Laura.
Okay, thank you. Laura Magaña from the National Institute of Public Health in Mexico. I would like just to hear your insight, your recommendations in order to how do we address in the framework the non-health professionals Although we are a committee on educating health professionals, but if we talk about social determinants of health, we really need to go beyond that. And I know that the task is already big, but I think it will be a mistake not to talk about what do we do, how do we integrate, how do we communicate with the non-health professionals. So if you can have some insight on that, I would appreciate it.
So there are a number of groups that are outside of health that are required on a global perspective to change some of this. And one would be law. One way to capture that, Georgetown, for example, University of Toronto, have whole groups that work in this area and have large international collaboratives trying to essentially change legal education to include that. So as you kind of think of things that are outside our area, there are experts who are equally concerned about social determinants of health to capture their wisdom within the framework that you create.
I would also add that part of the effort to train students to work in teams, team-based care, a lot of the team-based interprofessional work that's moving forward does take into consideration that there are other providers of care or other people who are interested in the care experience or who are involved or affected by the care experience that should be involved in the team. So bringing in some of those interprofessional team-based concepts into the training and not having this be all parsed out separately as part of an integrated curriculum. I know the arguments about who has time to put that in the curriculum is already overcrowded, but integrating team-based concepts, including those family members, other providers, and other people who are not traditionally a part of a care team into this, as well as the focus on social determinants, should not be too separated, too distinct.
Thank you for having the opportunity to ask a question here. To what extent would you like us to think about the diversity of the health workforce and the pipeline of workers that gets them there? And as kind of touching on a comment made by Joanna about how K through 12 education, early education might matter, and the exposure to a health science curriculum early on might matter to later decisions about entering a health career.
So I will say at HRSA, we've for a long time made the link or the connection between students from disadvantaged backgrounds, specifically racial and ethnic minorities, that they're the ones that are most likely to go work in a disadvantaged community, to have some insight and be aware of the social determinants, because oftentimes that's been their own personal experiences. But we also take the approach that they are not the only students that should be responsible for understanding and being aware of social determinants. So there's been historical link, the matching, the cultural advantages that you gain when you have a match of the provider and the patient. Also the increased communication. We know those are advantages, but those assets and those activities can be taught to all of our health professional students. So I don't want to see only the disadvantaged, targeted for this type of, exploration. Many times they are aware of it because they've lived it, but to have this be fundamental, that all students are aware of the factors that are operating beyond what is visible in the classroom, I think is important.
So just to add to that, my comment actually was broader. I think health literacy is horrible in this country, and so you don't have a prepared field. If you want to advance understanding, you have to have some basic level of understanding in the community, and if we started at a different level, then we certainly have more hope of making advances than we do right now. I have to say it's pretty abysmal.
Hi, good morning. Thank you so much for this opportunity. I have two questions. One speaks to a comment that you made early on in your remarks, Shanita, about sort of the integrated approach, and I think maybe integrated team approach, but also integrated curriculum approach. And so as we're thinking about this, some of what we had a little bit of a conversation earlier about is, you know, to what extent is this standalone given all of the challenges of already a busy curriculum, and to what extent is this integrated in? And so if you guys could speak to that as to how you would like to see that come out in the framework. And then the second question is a little bit more of a scope, and this speaks to the fact that this is the Board on Global Health. And I feel a little like we in the United States are light years behind our colleagues across the pond in our discussions of the social determinants of health and sort of where they are. And so to what extent are you looking to see what is the balance that you're looking for of sort of what that framework might look like given a US-based sort of system versus more of a global perspective of how we integrate into health education and training?
Thank you for those difficult questions. So for me, this is just my personal opinion, but integrated is always preferred, because if it's, you know, something I add on or an addition, it can easily be lobbed off when no one's looking. So to integrate it, if you could find an opportunity to do that where it makes sense, that it's coherent and it doesn't put graduating students at a disadvantage, or doesn't put the public at a disadvantage, because again, we're trying to graduate a qualified workforce, and we're also trying to scale up the existing workforce to give them also these skills as well. So we have two populations, the students as well as the existing workforce. And also the same issue, I think when we start to look outward and not see ourselves as the center, that we take a global perspective. Poverty works the same way no matter where you live. It's just more magnified in those countries that need additional resources that don't have the resources that we have. So if it works here, it should work anywhere, taking out the resource variable. But if it works other places, it should work here, the reverse. So it should be some universal concepts that stand out in these frameworks that address the root causes or the underlying causes of what we call social determinants.
I just, the other, just to sort of to emphasize the importance of that, you know, the integrated learning experience, because it really helps those students as they enter the field, that they've been exposed to the different concepts, the definition and language of the other disciplines, which really puts them on the fast track in terms of being a team member who can actually understand the perspectives from the other disciplines. And then oftentimes the communication can get crossed because we're using definitions and terms from the different disciplines, and we think we know what that definition means, when in fact it needs some explanation. But having that educational experience that exposes you across disciplines, those folks are going to be more prepared for teamwork.
So I agree entirely that integration into all of these collaborative curriculums is the only way to go. The question then is, within the time we have with students and faculty and professionals, how do we lifelong integrate work in this area? When you think of something, so my field, let's say HPV vaccines, if I'm only teaching what that means, how they were constructed, what the side effects are, what we learned in Costa Rica, I'm going nowhere. If I'm teaching, how do you get a community to think about this and incorporate it, and why did it work in Australia and it didn't work here? And how do we change that? And what does it mean for women long term? Then I've done more. And someone's likely to think that way when they're in the community and they think of the community as part of their responsibility instead of just the one patient in front of them.
And I have a quick comment on the global versus national part of your question. This work is being done through the Board on Global Health. And the forum is a global forum for health professions education. And many of you on the committee have deep international experience. Some of you are living and working in countries outside the U.S. Some of you have. This is not an accident. We really do need to think about something that will be used globally with the understanding that the U.S. is part of this global world. And yes, we have many examples from here. But as you've heard from our representatives of the sponsors, this is a global problem. And we in the U.S. And to some extent Europe, probably sometimes unfortunately, have set the template for health professions education. And we continue to influence health professions education. They look to us now increasingly. We were talking yesterday in public health. Universities around the world are now looking to be accredited by the U.S. accrediting agency. So we have an influence on health professions education globally. And I think that was an excellent question to help us keep that in mind. Yes.
Hi, thank you. My name is Nancy Carter. I'm president of Carter Foster International, mobile health and global health consulting firm. I'm former advisor for global health at the U.S. Department of State and have worked extensively in this area for almost 30 years. I very much appreciate the recent comments that were just made about global health, and that was one of my concerns, that there be the integration, because I think we can learn as much from the other communities, the other nations, as they can from us. Also, social determinants of health is an international phrase. It's something that's come out of our international negotiations, and it has a much broader framework than I've heard discussed here today. And I would hope that we could consider, as we're talking about access to drugs, we're talking about access to health care in terms of how many people are being served. Clearly, Ms. Williams mentioned a problem that we have with educating and keeping African American professionals in the healthcare field. It used to be a big field that was one of which we were very proud to have black doctors and nurses. I have sat around IOM's forum as a member of the forum in the past. I've sat at NIH working on various committees, and I can tell you the number of diverse healthcare professionals was few and far between. I would be interested and hope that maybe something is underway to look at a study as to why that has changed. Why are we not able to keep our African American students and other members of diverse communities in the healthcare field? What is making them drop out early? And how can we work to reverse that? I think it's important as a social determinant of health, because if people don't go into the field, they don't see anybody working with them that looks like them, and they don't get the language and the education about the importance of health. I think also if we can do something more on prevention, that's a very important part of health. It's not just looking at treatment and health outcomes, but how do we keep people from going into the system to begin with because of better health, looking at the environmental and other factors that go into that. So I hope that you will, although you want to focus, that you not miss out on some of the other very important issues that are very important to this discussion and which are being discussed internationally as we speak as the new session of the Youngest starts today. Thank you.
I think I'm aware of 3 more people at least who want to speak. Go ahead and come back here and back over.
Okay, thank you. Hi, I'm Darla Spence-Coffey from the Council on Social Work Education, also a member of the Global Forum. First, I want to thank the Consensus Study Committee for taking on this task. I was part of the small group of folks that helped to shape the statement of task, and even as we were doing it, I thought, oh my God, we're asking you to fix everything. So I thank you for stepping up in this way. I'm a social worker, and so I'm thrilled that we're talking about social determinants of health. I also have a slight nagging fear that this not turn into an exercise in helping us feel good, about paying attention to something that we value and that we really are able to move this forward, because well, I'll just leave it at that. Because that's the big challenge. It's obvious that people in this room care very much about addressing this, and we need to figure out how to make some real substantive steps forward in this regard. So I'm actually going to refer to the statement of task, because as it developed, there were really two parts. And the first part is more like the value proposition that I just mentioned, also very much about the learning environment and how we prepare students for health professions to care about, address the social determinants of health. And then there's the next paragraph that talks about how do we sustain this. And I really am asking if you can help us figure out some concrete ways to move this forward in a sustainable model. Because we can teach students that it's important to have one patient, one person, one plan, but if they go into a practice setting where the structure and the billing models and everything else is one patient, 8 plans, it's not going to work. Like, this is really about the intersection of education and practice, and that's where the promise is. We can really create some leverage here and make some change in that regard, and I thank you for how you're going to help us do that.
It's on. Satya Verma, National Academies of Practice. I may be completely off base, but I think, and this is a very important task that we are undertaking, but I still feel that this is just scratching the surface and not really getting to the bottom of the helping the real people that we need to help in the trenches. Part of the thing is, it's like you brought up the issue of that we have schools and colleges, we have places for the minority to, but we are not having students go in those places. So I think what we have to look at is go back to our families, back to our culture, back to our roots, and make sure that we need to educate them first. I think we should learn from the healthcare corporations, okay, how they are doing their business. When they manufacture a drug, they may or may not educate the physicians or prescribers, but they definitely go and educate the public who is going to use them. They bombard them with the information every day on the commercials so that they go back and seek out and ask their doctors, their prescribers, well, how about prescribing me this? So same thing happening with the insurance companies. When they insure, they don't tell the insured person actually what their benefits are. Okay, because if they did tell them everybody will be using them and they will be out of business soon. So I think what we need to do is look at how do we address this, because even if we educated all our health professionals about the social determinants, but if we did not include the society in the whole process, I think we will still be scratching the surface. Thank you.
Good morning. Patricia Hinton-Walker from Uniformed Services University. You know, as I've listened to the dialogue, and I've been at many of these dialogues around social determinants of health, and I think so many times we're actually saying a code I don't think we know we're saying, and that is social determinants of health care. And I just would like to come back and say, how is it that we might look at the real determinants of health? And one of those major determinants is nutrition. And when I look at, I don't know about pharmacy, but I can speak to nursing and medicine, we have almost no content in our curricula about the relationship of nutrition to health. So you look at food deserts, you look at the challenges that we have, and you know, I do agree that there are a lot of things around health literacy and all of that, but how is it that it's not really an add-on so much as it's a way of looking at the necessities that relate to health, nutrition, environment, stress? We're down the road fixing the problem instead of looking at what's upstream. And I think some of that isn't rocket science, you know, from an OB perspective, it's the next You know, it's the next generation. And then I would just say, as a side to our speaker before, what I found as former dean was that the reason my students, my minority students, weren't able to stay had nothing to do with their academic performance. It had to do with family and structures within the family for support. And so I think we need to look beyond just the healthcare delivery and really get back to what I consider to be the basics. And I think everybody here thinks that, but how do we address that? Some of it's political, some of it's economic, but if we don't, in our communities, speak up to say there isn't a place for them to get fruits and vegetables, there isn't a place for them to get good food that nourishes the brain, because you can't make good decisions without that. Thank you.
Thank you. It'd be great time for at least one more comment.
Thank you. It's John Weeks, participant in the IOM Forum. I really want to follow on what Patricia said, but from a slightly different take. I think one of the ways our community has been responding to the kind of lack of addressing some of the determinants of health has been through the beginning to model different forms of medical and health practice. It's showing up in lifestyle medicine as a new movement in healthcare, in functional medicine, and inside of the academic health world, integrative medicine, in the community, in acupuncture medicine, and in naturopathic medicine. And these fields have in common that they're holistic, that they model practices where you take the time to actually work with stress, work with nutrition, talk about family situations, talk about environmental issues, talk about what's going on with toxins in your household. So there's a lot of the work that's been going on in our communities, going on in our medical systems, that's trying to address these at the practice level. And I would say, to support what Patricia said, it's relatively low-hanging fruit. It's things we can address these in clinical practice, and we can address them in clinical education, bring them into clinical practice. So I would really hope that the committee will look at the models that are showing up out there. They exist in accredited programs here and abroad, and take a good look at them.
All right. Without another burning question, then I want to give us time for transition, but I want to say or did you have something, Sandy? You want to add? No? Okay, that's where we're going. So I did want to say you've now heard a lot of discussion, and I'm addressing the committee. And it's obvious that one study, especially a fast-track one like this, is not going to solve all of the problems that you heard about. I would urge you to keep looking at that statement of task and think about the fact that the work of the IOM and now the NAM is incremental, that you're not the first and you won't be the last. Make it count and focus on the statement of task. And it's a very large one as it is. And on behalf of the members of the forum and on behalf of our sponsors, I want to thank the committee for taking this on. And I want to thank our panelists for representing the sponsors of this study. Thank you.